we're now going to have our discussion on aging and muscle and bone. So I'd like to ask my co-chair and the other speakers to come up to the podium, and we're going to re-screen those questions that we sort of began with. And once those are up, I think we can start the discussion. But I just want to make a couple of comments about the session and some of the things that we heard. As one of the co-chairs of this, I didn't want to leave without mentioning a few things that I thought about. First of all, it's very insightful to me, and I think others here, as someone who's been involved in some of these consensus development groups on sarcopenia, and who's really interested in trying to understand how muscle contributes to age-related dysfunction, to hear about some of the historical perspective with osteoporosis, because I think the successes that Steve Cummings mentioned in terms of developing treatments in bone loss are really not there yet when we talk about muscle. So I think although they are different tissues and some of the endpoints are different, I think there's an awful lot of information and a lot of history that can help guide this field going forward. And I think also hearing a little bit about sort of mobility and sort of normal mobility or adequate mobility is really being the central sort of final common pathway of these bone-muscle interactions that we've been talking about and we're going to talk about for the next 2 days is really important. And then I think this whole issue of fat and fat loss and its effects on muscle and bone that Tammy highlighted is really emerging as still a very open debate. And then finally, in the last presentation, sort of taking us back to the beginning, trying to understand the role of mitochondrial biogenesis, whether it's in brown fat or in muscle, and the implications for that on bone loss and muscle mass, I think is really, really important. But back to the sort of key questions, maybe just to open this up to discussion about key clinical measures to drive evaluation and drug development in sarcopenia. I don't know if Steve or Stephanie has any comments about that, but sort of where we are with that now.
I just wanted perhaps to bring this up for advice from everyone, which is I'm excited that we have people here talking about development as well as aging. I'm struck that there's some mix of genetics and development that lead to a body size in young adulthood that we haven't really accounted for at all when we think about sarcopenia. Sometimes when I give my talks, I have a picture of a bulldog and a greyhound up there, and I'll say, I'm from the bulldog heritage, and I am never going to have a low BMI, and I am going to be near death before my muscle mass looks anything like one of those little Asian ladies. But so I was wondering if, as we develop some sense of what we expect from muscle in late life, it would be interesting to say, what's the expected muscle mass given your skeleton? And that you talk about, I think it was periosteal circumference or something. Is there something about bone size? Is there some relationship between muscle mass and bone size that's normal in young adults? And we could look in older people and see if you don't have enough muscle for the amount of bone size you have, not density, but magnitude. And I guess I also understand that the weightlifters talk about something about how much muscle you can make relative to how big your bones are. So I'd just be interested in comments. Is there somewhere to go and trying to understand what a normal relationship in an adult is between mass and bone size that would help us in aging as we move toward a clinical definition?
Well, I think that you could use the data from N. Haynes, but I think that the problem is, I think that this issue of secular trends is very important, because if you think about the people who are old now, they were never big. they never had a lot of, they didn't have big bones and they didn't have big muscles. And, their frame size was tiny relative to people nowadays. I mean, I happen to sew. So if you look at the patterns and you look at the change in bone size on the patterns, you see that people had much, it wasn't just in the Civil War, but earlier in this century, people just had much, in the 1950s and 1960s, people had much smaller frame sizes than they had now. We have secular data from Iceland showing that as the original Vikings were about 6'2", and as nutrition changed, people got much shorter, and then they, and their time to menses got much later, and now with the restoration of the economy, people are now getting taller again. Diabetes is resurrecting itself, and menses, time for menses has gone way down. So I think that if you look at that data, you can probably come up with relationships, but I think you have to take into account the secular trends and try to figure out who your target audience is.
There's still probably variability, though, right? I mean, the means are different, but there's still big people and little people variability across any population, and if there's some sort of fixed relationship. It's just because I'm worried that there are no absolute values and that a relative value might be interesting.
So, Steve, are we always going to be left with sort of having to develop some sort of single arbitrary cut point, or is there any hope for sort of looking at a trajectory of change for muscle, for example? I mean,
well, I think you could follow people clinically with trajectories of something. I'm not sure what that thing is, but for purposes of clinical application, it's going to be a whole lot easier to have a single cut point of something that you can measure, and so a lot of this is driven by that need for clinical, for things like billing and simple actions to be taken. But the issue of then what do you monitor that relates to maintenance of function, I don't know. All of this is in the future. Right now, it looks as though both for clinical use and for drug development, strength is probably the best, is the best simple focus. And adding muscle is only going to be, I guess, advantageous as many of the pharmaceuticals are after, if the muscle that's laid down has the same quality or even better quality. And maybe it'll have better quality because it's younger. And it's replacing some of the old protein structures and organelles with new.
Eric,
So Steve, one of the challenges I think in this field that's different from the osteoporosis field is that in osteoporosis you have a very clear outcome, which is fracture. Mm-hmm. When we're talking about sarcopenia, then mobility disability is quite different than falls, which is quite different from body composition and its metabolic implications. It seems like this field is maybe more akin to hypertension, with a variety of outcomes that might be predicted by muscle dysfunction. Have you thought about how we might sum, or what's the most important endpoint that we might use to develop a cut point?
Muscle people look at the bone field and say, isn't it cool, you've got just one single endpoint, that's fracture. But those of us who work in osteoporosis know that the fractures are diverse. You're talking about vertebral fractures that have different kinds of consequences than hip fractures, than wrist fractures, which might be a marker of health. And so I think our endpoints are pretty complex as well, and bone density or bone mass and other things relate to them differently. But I mean, we're still at an early phase in muscle. I mean, the reason that mobility disability seems to be gaining a lot of traction is because it's extremely common. It has terrible effects on quality of life. And falls do as well, but falls, as Stephanie points out, are possibly even more complicated.
Steve, could you say,
So anyway,
could you say what mobility disability is?
well, mobility disability I defined on the slide, but that was probably went by quickly, particularly for some of us who are old and have trouble remembering things like the definitions. And mobility was essentially functionally defined as low gait speed. Some, if they have a 400-meter walk, means that you can't finish it in 10 or 15 minutes. And simply in your office, it's less than 0.8 meters per second. Functionally very important, because if you're below that, you really can't manage activities of daily living independently.
I think there's a comment from the audience, but I also think that thinking about gait speed as perhaps maybe a proxy or maybe a biomarker for other sort of disablement outcomes, maybe one way to think about it. But it's certainly one that's likely to be sensitive to change for intervention trials, and it also predicts by itself is a very strong predictor of other bad outcomes. So,
it's going to be hard to see how responsive mobility disability is. It might be, because it's so multifactorial and people get used to it. It's not as clear, whereas strength, clearly from exercise studies and others, seem to be very responsive to interventions. And so functionally speaking, I think strength will be and continue to be the sort of the focus for drug development and its manifestations in people in the first pass.
So comment, yes.
First pass studies.
Baron, Merck, two questions if I might. The first is, obviously, peripheral muscle weakness is a major cause of falls. However, if you take that to the extreme, where you're bedridden, you don't fall and you don't fracture. So, in practicality, in a clinical study, how does one separate peripheral muscle weakness from postural instability that then predisposes to falls?
Sounds like a Stephanie question.
So I think it's possible to operationally define the components of postural control, by which I mean that whole set of sensory, central, and effector things. You can look at a variety of physiologic indicators that really separate them, or you can look at a variety of so it depends on what you mean by postural instability. If you're talking about things like sway, strength affects that as well. So you're trying to separate strength from
I'm thinking
central
of it like
control,
either
balance.
auditory, vestibular, retinal factors that may then control our postural stability, which then increase the predisposition to falling, about which a drug intervention for muscle strength, let's say, is going to have absolutely no impact.
Yes, and so you can assess vestibular function. You can assess a whole world of different visual. You can assess for peripheral neuropathy, which is a powerful sensory driver of instability. Your first point, though, is very well taken. As you get in a bigger picture here, it's important to remember that the relationship between mobility and falls is not linear, because if you have very low mobility, you don't fall because you can't move. And so we used to say you have to be able to move enough to fall.
Falls too are very heterogeneous. I mean, I've fallen 2 or 3 times this year, but it's always been in athletic situations that I shouldn't be in for my age. But it's not so much the fall, but it's the nature of the fall, and it's been shown, in a couple of cases where falls that happen without protective responses, that tend to happen without obstacles in your environment, that just mean you're collapsing, you're falling on your butt or you're falling on your side, indicate a kind of weakness or a kind of neurological dysfunction, that means that you don't have defenses against the injury. And those kinds of falls are not easily measured in our studies, and therefore the risk factors for those kinds of falls have been, as far as I know, unknown. So I think when we're talking about falls, I think from here on it's important to be much more sophisticated. It's not number of falls, it's not the risk of falling, it's not falls leading to fractures. I mean, we're dealing with a certain type or set of falls that You know, they're very difficult to study without cameras surrounding your environment to show you how you did it.
And could I just ask Cliff a quick question? Individuals with anorexia nervosa have increased marrow fat. They tend, and oftentimes, to exercise more, which, according to your paradigm, would theoretically increase irisin and promote brown fat and prevent bone loss. So is the fat in that marrow white or bright?
Yeah, so it's very hard to image fat with PET scanning in the marrow, even in humans. We've tried, it doesn't work. We've imaged the preformed brown adipose tissue of about 30 anorexic girls at Mass General. None of them show uptake of glucose, FDG glucose, suggesting that their preformed brown adipose tissue is not functioning very well. And indeed, one of the hallmarks of anorexia is low body temperature. So the question that you asked is sympathetic tone upregulated to compensate? We don't know. It's very difficult to measure sympathetic tone. Resting heart rate's terrible because it's affected by so many factors, although Dr. Cummings many years ago showed that increased heart rate was a major risk factor for fractures, hip fractures in older individuals. But I think we really need to be able to define how we measure sympathetic tone before we can understand. But it looks like, and what Ann Klebanski tells me, is the anorexics really have reduced energy expenditure and have really clamped down, and their sympathetic tone is probably low.
Comments?
Casper from Oxford. Steve, I really liked the direction you were going in. One thought I had, what about people with large joint arthritis, such as hip and knee arthritis, whereby maybe an arthroplasty might solve one of the mobility, disability, or the walk speed problems? How will the sort of risk profile assess those patients?
Well, if you're talking about mobility disability due to other causes, I mean, it's part of the risk profile that will identify, you know, high risk of mobility disability. But the treatment that you would apply to that is very different. And so mobility disability, I think, has got to be, you know, as Stephanie's group at FNIH is talking about, mobility disability attributable to a muscle characteristic like strength will have a completely different meaning clinically, pathophysiologically, than mobility disability. Like osteoporosis due to secondary causes, fractures due to secondary causes, so that may be in the ballpark of mobility disability due to other non-muscle properties like having had a stroke.
Okay, so we'll have to x-ray all these people and exclude OA.
Well, to exclude OA? No, not necessarily. I think your field has shown me that WOMAC and painful OA can be gotten at by questionnaires.
So I think it's important to understand that, at least in all the old folks, they don't have just one cause of their mobility disability. They have multiple causes, and you're not going to exclude arthritis, which occurs in half the people. I think it's important to remember that these things all affect each other. So many people with arthritis have secondary muscle wasting and secondary weakness, and I think there are opportunities to ask the question whether weakness due to pain and inactivity can be addressed in a number of ways. Those people may have trouble with exercise, whether you can accelerate recovery after joint replacement or treat before joint replacement in order to accelerate recovery by addressing the concomitant muscle problem. So I don't think, at least in aging, we're done with like pure homogeneous groups. It doesn't work in aging.
Steve introduced a very practical concept of drug development and billing, so I'm going to pursue that line for just a minute and give you my experience in the bone field, and also earlier in the field of growth hormone, where Cliff and I actually had collaborated. It's quite clear that to get registration of a drug, endpoints such as body composition will mean nothing to the FDA. And what they demand, particularly when the subject matter was growth hormone and IGF, what they demanded were some very practical daily life outcomes. And that has not changed at the FDA, because most recently I was involved with some discussions with them concerning acceleration of fracture healing. And they were not interested, particularly, in the acceleration of healing of a fracture, except insofar as it might mean fewer days lost from work, being able to do certain activities of daily living more effectively. And so those are the kinds of endpoints I predict are going to be necessary to show in any kind of clinical trials you may anticipate in pharmaceuticals aimed at restoring muscle function.
Those are excellent points to sort of conclude with, Bob. And I think the FDA is continuing to seek guidance about what the right endpoints are in clinical trials that are targeting muscle-specific syndromes and diseases. And I think that discussion is ongoing. But one last question from Steve Cummings.
Yeah, I get to ask Cliff one question with two parts. One, you know, it looks as though this is a mitochondrial thing. And mitochondria provide energy, and all of these processes you're talking about, I mean, we talk about maintaining bone with osteoblast and osteocyte function and maintaining muscle and regeneration of muscle are energy requiring processes. And is it not just as simple as we need energy for all the processes that maintain tissue? And secondly, on the flip side of that is mitochondria and their dysfunction or decrease in number also control apoptosis, which you didn't measure. And so decrease in mitochondrial function or content in organs will tend to lead to the disappearance of those cells in atrophy.
Yeah, so let me emphasize that we know nothing about mitochondrial bioenergetics in bone cells. And we've just started to look at it. And we think the time of the most energy demands are during collagen synthesis. I don't think that's illogical at all, but we've started to look at stages of osteoblast differentiation, and there's this tremendous upregulation in bioenergetics, and in particular oxygen consumption during collagen synthesis. So we're trying to understand in the niche and during stem cell recruitment, do you need specific machinery for that kind of bioenergetics to allow that cell to go down that particular pathway? And in addition to that, you're right about apoptosis, but also reactive oxygen species. So aging is associated with this tremendous increase in reactive oxygen species, and that's suppressing mitochondrial bioenergetics. So that's another major suppressor in bone formation with age. And my feeling is until we change the paradigm and start thinking in terms of whole body metabolism, we're not going to get at those particular issues. So you're absolutely right.